I don't know, I guess I'll record on the computer. It gives me way too many options here. And I'm going to share my screen, and the screen's just going to be a whiteboard for now. Okay. So can y'all see that? Okay. So we're going to talk. Feel free to gather around and pull up a chair here, because we're all sitting around one computer here at the station. And here are the things that I want you to get out of tonight. There are just three things that I want you to get out of tonight. I want you to know the reason why someone has an LVAD. So that's going to kind of deal with cardiac pathophysiology. So we'll talk a little bit about the anatomy of your heart and what happens to it, the disease processes that prompt someone to get an LVAD. We'll talk a little bit more about the pieces or the mechanics of an LVAD, or RVAD, if we're doing anything on the right side of the heart, and then common problems or considerations for the EMS provider. And that should take about 30 minutes to get through. So here's what I'm going to do. I'm going to switch over. I'm going to move my little bar down here. I'm going to go to the draw tool, and I'm going to draw you a picture. We'll see how well it turns out. So here's what I'm going to draw you a picture of. It's going to look kind of like a T-bone steak, but this is not a T-bone steak. I'm making myself hungry here. This is your heart, and you got two chambers on the left side of the heart here. You have your atrium and your ventricle. And what the left side of your heart does is it pumps oxygenated blood to the rest of your body and down to the tissues, where it branches off into smaller and smaller blood vessels like capillaries. Oxygen is offloaded, and waste products such as carbon dioxide are picked up. And then your deoxygenated blood comes around, and it's received by the other side of your heart. It's received by the right side of your heart. The right side of your heart also has an atrium and a ventricle. And then somewhere in the middle of this connection right here, you have your lungs. And that's what's supplying the oxygenated blood back to the left side of the heart. So this is just the basic physiology that we see in someone that moves oxygenated blood around. So we'll call these down here tissues, basically anything cellular that requires oxygen. That could be something like your skin. That could be something like your gallbladder, which people always complain is a useless organ, but it could also be something as important as your brain. So this oxygen exchange occurs all throughout your body. So the purpose of having a ventricular assist device is the ventricles are responsible for actually squeezing the blood out of the heart. And in certain parts of your heart, that muscle needs to be thicker than others. And this is especially true for the left side of your heart. The muscle is thicker and stronger there and has more of an elastic recoil, because the responsibility of the left side of the heart is to push blood all the way out to all of the tissues in your body, whereas the right side of your heart only has to squeeze the blood out to the lungs. So the right side of your heart is a much lower pressure system than the left side. So when we're looking at putting in a ventricular assist device into someone, it is really because something has happened to the muscle of the heart that is causing it to not work anymore. So what we are seeing in a patient with a need for a ventricular assist device is some sort of cardiac disease that weakens the muscle. Okay. And can you think of any types of diseases that might weaken heart muscle? Congestive heart failure, yeah. Anything else?
A previous heart attack.
Yep, a previous heart attack. Anyone ever heard of cardiomyopathy? That's a very long word, but if you break it down, cardio meaning heart, myo meaning muscle, pathy meaning disease of. So oftentimes in someone who has chronically uncontrolled high blood pressure, you can put additional stress on the heart muscle and cause it to either thicken up to the point that the space is no longer effective to receive blood to pump it out, or you can stretch the muscle out to the point that the elastic is no longer effective and it struggles to push blood out. And you can kind of see that these types of diseases, all three of these, have that similar similar interconnection. If you see one, you could be at risk for some of these other ones, and oftentimes these cause your heart to fail. And then the only other one that I would put in there is some sort of infectious disease, bacterial, viral, could also put additional strain on your muscle and cause it to scar or weaken in some manner. So these are some indications for someone requiring a ventricular assist device. So what are the intentions of someone who is receiving a ventricular assist device? Well, I think the best way to answer that is to kind of tell you a little bit more about what a ventricular assist device is and what it looks like. So basically, a ventricular assist device is a fancy pump that connects the bottom of your ventricle with the outgoing blood vessel from that chamber of the heart. And there's a pump in the middle here that's basically shuttling the blood from the ventricle up to the exiting vessel on the corresponding side of the heart. It is meant to be the pumping power of the ventricle. So it's a ventricular assist device. It does a lot of work to take the work off of the ventricle. Sometimes it does most of the work. Sometimes it's just supportive work. And it's usually reserved for people who have failed some sort of medical management, such as medications, lifestyle changes, and other things. It is, as you can imagine, based on the place that we're putting this inside the body, it is not an easily serviceable device, which makes it a little more of a high acuity thing. And sometimes people have this for the rest of their life. Sometimes people have this while they are on a candidate list for a heart transplant. And sometimes people are on this temporarily until whatever the acute process is resolves and their heart heals up. And that's probably one of the least likely scenarios that you will see in someone with a ventricular assist device. More commonly, you're going to see that this is just meant to be a supportive measure for someone to bridge them the rest of their life, or to get them through until they can find a donor heart or heart transplant. Any famous people come to mind for you when you think of ventricular assist devices?
Dick Cheney.
Dick Cheney is probably the most memorable person that we can think about when it comes to ventricular assist devices. And if you ever look at a picture of him, and I encourage you to, on the side of your screen, Google him right now, you will see a picture of him with the two shoulder straps with a battery pack on either side and a drive line that goes underneath the skin and connects to the ventricular assist device. It's a pretty impressive thing. And then he wound up getting a heart transplant. So that was a bridge to transplant type therapy. Everyone good with the physiology, pathophysiology of this disease here? I'm going to hit save, and then I'm going to clear the drawing.
Very impressed with your drawing skills.
Oh, I thank you.
Yeah.
I've learned how to compensate for some of the features on Zoom here that aren't terribly nifty, but it also helps to have a touch screen too. Alrighty, so I'm going to go back to this, and we're going to kind of draw a picture of the heart. And again, it's a 5-cent picture, but it will do. And we're going to kind of think of this as being inside the body. And then we'll think of this as being outside. So we have the two ends of the pump. And we're going to use the left ventricle here because this one usually requires more support. You have the pump, and then out of the left side of the heart comes the aorta. So the pump usually connects somewhere in the aorta just above the point it exits from the heart. You're going to have this thing, this wire that connects to the outside that's called a drive line. And on the outside, usually strapped to the person's waist, you will have a console. And on either side of the console, you should have a battery connection. So someone with a ventricular assist device will have a console that's usually visible and a couple of batteries. And the purpose of having a couple of batteries on this is so that there's a redundancy. If one battery dies, the other one takes over. And you can imagine, and it's simple enough when you think about it, that when you change the batteries one at a time. You replace one battery, then you replace the other. You don't pull out both batteries at the same time, because what happens? The pump stops working. Now, in certain patients, again, it really depends on how much work the ventricular assist device is doing for the patient. If you were to pull both batteries out, you might see absolutely no change in the patient's condition. You might see some mild changes in their level of strength and respiratory effort. And then there are some patients where the ventricular assist device is doing most of the work, and pulling out both batteries at the same time basically puts them in cardiac arrest. So if you have to help a person change their batteries, or you come across an unresponsive person and you're changing their batteries for them, you need to change the batteries one at a time. And as we talk about problems that we might see in EMS with ventricular assist devices, the first thing that you want to start with is the batteries if the console is not telling you anything about what is wrong. And in general, regardless of whether you go to someone who's having a cardiovascular emergency, or you're going to another type of emergency that a patient with a VAD is having, and the VAD doesn't really play a huge role in the problem, you want to make sure that you're always taking the patient's batteries, spare batteries, charging system, and spare console with them. All the extra parts that that person would need to survive away from home. It's very uncommon for hospitals in rural areas such as northern New England to actually perform this procedure where they install a ventricular assist device. So if you depart the patient's home and forget to take all of this equipment with them, it is not likely that any of the hospitals in our area would be able to supply that equipment. And if they are running out of time to get back to their house before the pump dies, we might be up a creek without a paddle. So please, if there's anything that you remember first and foremost, if you come across a patient like this, regardless of the reason that you're called to their house, make sure that you take their supportive equipment with them if you have to take them to the hospital. So that's rule number one. And that's, again, trying not to get lost in all the details of the ventricular assist device. Always remember that. And we all do that decision-making together. We're all responsible for that. So none of us forget. And sometimes, just like we talk about with patients with other medical equipment, I think of patients with tracheostomy tubes, I think of patients with feeding tubes, and other different types of devices. You might get called there, and this hardware might be in the patient, but it's not the actual source of the problem. So when you get to the scene, you gotta ask yourself, what is the real source of the problem here? And if the answer for this VAD is not cardiovascular, then you should continue with routine patient care as you normally would in the field, with the exception of remembering to take the batteries, the extra charging station, and the extra console with you. Did I mention that you should take the batteries with you if you transport the patient, as well as the charging station and the console? Okay. The one thing that is going to be an absolute screw up is if that doesn't happen. If it is cardiovascular, however, in nature, you might have to do a couple of other things to troubleshoot. And in your cardiovascular assessment, you're going to find that a couple of things change. Okay, first of all, when we do our ABCs, you're going through airway, breathing, and circulation. What is the one vital thing that is essential to circulation that we assess on every patient? Pulse. Yes, absolutely. So we want to make sure that their heart is pumping. Here's the thing about someone with a ventricular assist device. In most of the models that you will see on the market, the pump is continuously pushing blood, continuously feeding blood. It is not squeezing intermittently like the heart is. So what happens if you go to actually palpate a pulse? You're not going to be able to feel one. Huh, that's kind of scary, right? So on cardiovascular assessment, it might not be possible to palpate a pulse. So I'm going to throw this question out to you. What tells you that a patient's cardiac system is functioning? Okay, we talk about perfusion here. So what tells you that someone is perfusing well?
Skin color,
Yeah,
their cap refill.
yeah. Good, great minds think alike. Sandy just said the same thing. What else?
They're
Mental state.
alive. They're alive.
That's right. That's right. Something tells you that this person's heart has not stopped. Mental status means that they are adequately perfusing their brain. Capillary refill and skin color tells you that they are able to bring blood to the capillaries. So those are all good things to know. So this tells you that the perfusion is good. What tells you that the pump is working? The console being on would tell you that the electronics are on and well supplied with battery. Believe it or not, if you take your stethoscope and put it over the heart, you will hear a pump-like whirring noise or buzzing noise. It literally
Really?
said, you know, imagine firing up your generator, or imagine some sort of continuous pump flowing, but just on a much softer level. You're not going to like hear it 5 feet away from the patient, but if you put your stethoscope on the patient's chest, you will hear it.
Kind of like an aquarium circulating
Yeah.
pump.
That's a great way of thinking of it. That's absolutely right. Yep, an aquarium circulating pump is a great way to think of it. So this all has to do with someone's circulatory status. So let me ask you about another vital sign, blood pressure. How do you wind up obtaining a blood pressure on someone normally? What do you have to do? Not talking about a VAD right now. We're just talking about how you normally take a blood pressure on someone.
Sphygmomanometer.
Gesundheit. So Sandy says with a
Yeah, that's right.
sphygmomanometer, a blood pressure cuff, and a stethoscope.
Right.
Okay, so you inflate the blood pressure cuff. You put the diaphragm of the stethoscope down on the patient's arm. You slowly deflate the pressure from the blood pressure cuff. What tells you what the patient's systolic blood pressure is?
The high-end reading.
The high-end reading, and you start to hear
The pulse pressure. Yeah.
So we already see a problem with this, right? You're not
It's-
going to be
yeah.
able to take a manual blood pressure on this patient.
Okay.
But here's a nifty thing. You might be able to get an automatic blood pressure on someone. Because the technology that automatic blood pressures use is not listening for a pulse. It is a high frequency oscillation. And you might at the very least be able to get a mean arterial pressure on the patient. You might not be able to get like a systolic and a diastolic that's accurate, but you might be able to get a mean arterial pressure. And that's terminology that a lot of healthcare is moving toward when we talk about shock, like hypoperfusion. They want to target someone's MAP for 65 or greater. So that number is that little parenthesis number that you see underneath the systolic and diastolic blood pressure when you take them automatically on the ambulance.
Right, but like Brenda and I in the field are not going to have that capability.
Absolutely. And that's when you turn to your other signs of perfusion and
Okay.
base your assessment off of how the patient looks. So you got a couple of different ways of thinking about what is going on there.
Tyler, does one of those over-the-counter like wrist cuffs that are self-inflating automatic, would that work as opposed to the traditional pump it up and release the air that we normally do in the field?
You know, I don't think, I think in general, the home use automatic blood pressure cuffs are subject to a lot of user error. And because most of them are distally set up, a lot of the ones that I see are meant to be a wrist one. I think it's a little bit of a stretch to trust it. And I would say that the best tool that you have in your toolkit is your own ears. And I would certainly say that in most cases, you know, this is a very rare exception that your manual blood pressure is going to be so much more reliable.
So what are we going to see with pulse oximetry?
That's an excellent question, and that might be a little bit iffy as well. You're not going to because pulse oximetry also depends on circulating pulsatile blood. So,
but would we get a fair oxygen saturation or not?
excuse me,
That's okay.
I just inhaled a mast fiber. I think for there to be an accurate reading, you have to have a pulsatile motion coming through the pulse oximeter, even with the oxygen.
Okay.
So that's gonna go back to your, what's the patient's skin color? Are they struggling to breathe? Are they cyanotic? And using all of your senses to make a decision about whether someone needs oxygen or not. So pulling all those other tools out.
So I'm not sure if you're going to cover this or not, but let me throw it out there. So if we get a complaint of chest pain, we get there, they've got an LVAD, but they have nitroglycerin. If we can't get a blood pressure, how do we know whether or not we can administer nitro?
I would in general say that because this is a ventricular assist device, and someone's pressure is very sensitive, that you're probably not going to run into that situation, even with an VAD, very likely, because I imagine that there are some contraindications to nitroglycerin that a provider may hesitate to allow someone with a VAD to use it. A couple of things I will tell you is one thing that will save you is the fact that the patient has to be prescribed nitroglycerin at the EMT level to be able to give it. So it would be something that if you don't have the equipment, if you don't have the equipment to obtain an appropriate blood pressure, then you can't give it. You can't give it in your situation, and that's totally fine. It's the safest thing to do in that situation is to hold it.
Called medical control as well, or?
That's right. And when it comes down to things like this, use your resources. Resources are available to you, and medical control might hesitate a little bit, especially in the local hospitals, because emergency medicine physicians are a jack of all trade, master of none type deal. So if you tell them about an LVAD, they might say, LVAD, I don't even know how to spell it. That might be a little bit of a point of contention. What your protocols in the Vermont EMS protocol book recommend, and what most VAD manufacturers recommend, is that you call the on-call consultant for ventricular assist devices. So every person who has a ventricular assist device is sent home with a binder of information, and that includes a VAD, the contact information for the VAD coordinator, who is a medically trained professional who can be consulted for ongoing care and to help you troubleshoot issues that don't fall into a logical pattern. And that might be one of those things where you would consider doing that. And they're on call 24/7. So it's easy enough to place a call to them. The other types of things that you might consider, just monitoring in general for any sort of ischemic chest pain, you might consider a 12-lead EKG. Obviously, your airway and breathing are still going to be treated as you would find them in the field. So if someone's having shortness of breath, you would put an on-air breather on them. If someone's airway is obstructed, you would still manage their airway. One of the big things that people will kind of hesitate on is the fact that the VAD actually alarms. So if there's a problem that's going on internally, the VAD might alarm. And one of the things that the VAD will alarm about is, one, the batteries. That's like, again, going back to the problem being as simple as the batteries. And then two, sometimes you can get the VAD to send a message across the console that says low flow. And that basically means that the pump is not able to drive a ton of blood from the ventricle up to the exiting vessel. There's some problem that's preventing blood from flowing properly through the pump. Now, what kind of problems do you think might cause a pump to not be able to push blood through from the ventricle to the vessel?
Some kind of blockage.
Okay. Some kind of blockage. So it could be something like a clot that's forming. You'll find that patients who have ventricular assist devices are put prophylactically on some sort of anticoagulation to reduce the risk of that happening. That being said, it does happen.
Some kind of hemorrhage going on.
Yep, absolutely. There could be hemorrhage.
Fault with the pump itself. Mechanical fault.
Yeah, there could be, the pump could just be broken, or some element of the pump is not working.
Or there's another issue where there actually isn't enough blood to perfuse.
Okay, so that's actually probably going to be the most common reason that someone is in a low flow state, is they have some sort of hypovolemia, dehydration being one, sepsis being another. Any state that causes your body to not have enough blood volume for there to be an adequate flow through the heart, right? So severe volume loss could cause a low flow state because there's nothing there to really pump through. And that's an easily managed thing by EMS and giving the patient IV fluids. And if you consult with the VAD coordinator, that's probably going to be one of the things that they would have you start with if you have a patient who looks like they're poorly perfusing and the console is alarming low flow. The biggest piece of information that I was told by people who are smarter in this field than I am is that regardless of the alarm, the first thing that you need to do when you arrive on scene and hear this pump screaming, other than assess your patient and make sure they're alive, is to hit the silence button on the console. Yes, that's right. They put a really big silence button on the console, and you need to hit it so you can hear yourself think. That's really important.
Do you have a picture of this stuff that you can put up on the screen, Tyler?
Yep, I'm going to actually take you to a website that actually shows you some of this stuff here in just a
Okay.
second.
So I guess with respect to these rechargeable batteries, so the thing has got two batteries in it.
Yep.
And I assume, maybe incorrectly, that a patient is supposed to take one battery out and charge it.
So this is
And-
someone who's going to have at least 4 batteries,
Okay,
and oftentimes a spare charger and a spare console.
so if they've just been negligent or remiss in charging their batteries, what are our options? I mean, how long does it take for a battery, one of these batteries to charge? And is there an alternative to plug it into an outlet, the unit into a regular AC outlet while the batteries are recovering?
Yeah, that's a great question. So I wish I could tell you a little bit more about the charging efficiency of the batteries. I'm not 100% privy to how long it takes for one of these things to charge. Many models do offer a direct connection to electricity for a short period of time. I'm not sure that's a universal feature. There are 3 or 4 models of ventricular assist device on the market. And they're made by a couple of different companies, but there are some that do offer the direct charging as an option. It just wouldn't be a good option for a prolonged period of time.
So if someone has an LVAD, an issue with this unit,
Mhm.
it's going to be a transport, what, to Dartmouth or Fletcher Allen?
Yes, so here's the way that they divide it up. And it really comes down to, is it a problem with the patient's cardiovascular system? And more likely a problem with the LVAD, or is it something else? So if it's a problem that suggests there could be an issue with the VAD, then you're going to want to consult with the VAD coordinator on which hospital is going to be the appropriate destination, because they might encourage you to bypass the local community hospitals and proceed directly to a tertiary care center like Dartmouth or UVMMC. The other things that can go wrong with a pump, other than the fact that sometimes the pump will have that low flow state, is the pump can stop working. We already talked about how the battery, most of the time it's the battery, and you just need to correct that issue of electricity. Another thing that can happen is the connections can come loose, like the drive line where it goes into the console. So you want to check and make sure that everything's connected and hasn't gotten knocked loose. The last thing that can happen is you can have an infection at the site where the drive line goes into the patient. It's usually covered by a 4x4 gauze that has a little slit in the middle of it to wrap around the drive line. And if you pull that back and you see that there's pus or anything else that does not look healthy draining from that, that could be a sign that there's an issue there. But in any of those cases, they're going to encourage you to go to a tertiary care facility with this patient. And that patient's actually probably going to continue on that journey beyond there to a place like Boston or New York City or Hartford. And I don't know if Portland does these at all, but it's probably going to be a much larger facility that this person might require in the end if it is truly an issue with the LVAD.
Are there any of these units in our coverage area?
That is an excellent question that I am not sure of the answer to. I have not heard of anyone in our area who is actively on a ventricular assist device. I have been wrong before, but it has been historically a part of this agency's information sharing that we would get notifications from people in our area if they had some unique medical condition. And I don't know if you have any other knowledge about that or not, Sandy.
I know there were a couple in Morrisville when we first did LVAD training, and that's the reason we did the LVAD training, was because there were 2 patients in Morrisville that had them. So they just had the feeling that there'd be more exposure to them. But yeah, I'm assuming anyone that has one of those devices would at least inform the hospital, but whether that's also communicated to the EMS squads, probably not.
Yeah, I imagine, I imagine that's part of the education, right? So someone doesn't just get a motor for their body and then get kicked out of the hospital. There's a little bit of thought that has to go into this if you're taking care of yourself at home with a new piece of technology, or if you're going to be the caregiver of someone at home with a piece of technology like this. And part of that responsibility, it seems, would be to notify the local agencies that may be supplementing your care, that this type of device exists in your area. And if I had any knowledge of it, I would certainly share that with all of you. I've not been aware of any VAD units in our area, however. The last thing that I think is really important for us to cover in VAD education, as far as the different types of problems that you might see, is CPR. Because I think the big polarizing point for these ventricular assist devices is CPR. And there are certain situations in which you really, really, really should not be doing CPR. And there are situations where you obviously want to try whatever the least invasive method is to manage the patient before you start CPR. For example, the batteries, right? I keep going back to the batteries, but when you have a machine that's running blood through your body, you got to think mechanically like the batteries. Are the batteries dead? Is there a loose connection? Start with the obvious things first. And here's what your protocol says about ventricular assist devices and CPR. If the patient is in full cardiac arrest, which would be suggested by a completely unresponsive patient who has terrible signs of perfusion and is not breathing effectively, CPR should not be performed if there is any evidence that the pump is still functioning. The decision on whether to perform CPR should be made based upon best clinical judgment, which means, are you not able to fire up the ventricular assist device? Listen over the heart, see if you can hear the thing running. Are there indicators on the screen that suggest it's on and working? Have you tried some of the obvious mechanical things to get it fired up again? And you should also early on contact the LVAD coordinator or the VAD coordinator to start a discussion on CPR. And this is a very time-sensitive phone call that you will want to make, and you will want to explain what you have done to try to resolve the issue. And if you have in consultation with your VAD coordinator, your medical controller, if you're unable to reach either of them in your best clinical judgment, found that you can't get the pump working and the patient's still in full cardiac arrest, you are going to be starting CPR. That's pretty much the answer. So it's what have you done to try to fix the problem, and are you at the end of your possibilities for trying to solve it? Liz, you're muted.
So if the unit's alarming, when we arrive, they're unresponsive, how, and it's an unattended, unresponsive with the alarming. How long, if it's a problem with the batteries and you get the batteries and going again and you get the unit going again, and they're still unresponsive, I mean, what's the timeline on this? I mean, it's like an unattended cardiac arrest, right?
Yeah, so I think that is a one.
Maybe I'm not articulating the question right.
No, I think you are. So basically, I think what you're trying to say is you have someone who's unresponsive, their pump is dead, and you are troubleshooting it appropriately, like we just walked you through. You replace the batteries, but you're not certain how long the patient has been down for. And now you're restoring blood flow to someone and you're not sure how viable that person is, depending on how long they've been out for. Is that kind of the scenario that you're painting for me?
I think so, yeah.
Okay, I think I would defer you to your irreversible death protocol, looking for all the signs of death that you would in someone where you would not attempt resuscitation in the first place. If there's any chance at resuscitation of a person and your clinical assessment suggests that this has happened recently, I would start troubleshooting the VAD and I would get on the phone with medical control as soon as possible to determine what the best course of action is.
Do you use an AED with the VAD?
You can, yep. So if you find that a patient's in a dysrhythmia that you can defibrillate, you sure can.
Okay.
Alrighty, so I'm going to save this. I'm going to stop sharing for a second so I can bring you to the website that I encourage you to go and look at. That tells you a little bit more about how each VAD on the market works. Share my screen again. Go to the screen, and then you can see that's my little Zoom doc. This is my email. And this is website that you can go to that's called EMS Field Guides. And it's called mylvad.com. And then you can go to the medical professionals tab and it takes you here. And so these are here to help you identify, troubleshoot, and provide emergency care for the LVAD recipient. And you can see that as you scroll down here, it will take you to all of the different ventricular assist devices that are on the market, including this Syncardia total artificial heart. And basically in that one, they core out both ventricles. So it's not like you can fix that once you've done it, and it's just taking over the entire responsibility for the two. We don't see that a lot in North America. That is a popular device elsewhere. Most of ours are this HeartMate 2, this HeartMate 3, and then I think it's the Medtronic HVAD that we see in North American markets. So if you go through here, it kind of runs you through pulsatile and non-pulsatile devices, and it talks to you a little bit more about how most of them are not pulsatile, what a VAD is, what the controller does, what kind of power sources. So you can see here that they have both rechargeable batteries or AC power. You just need to make sure that you have the correct outlet. And on the ambulances, you know, we have outlets in the ambulance, but they're not necessarily going to, what are you going to do when you have to unplug the patient to move them into the hospital? So that's why we're thinking kind of forward thinking with making sure we have all the stuff. This shows you a picture of the HeartMate 2 and the HeartMate 3, the consoles that you see, and then the little shoulder strap batteries, as well as some of these other ventricular assist devices. So you'll see in these, you can kind of see this. I wonder if it shows a bigger picture as we move down. I like big pictures. Aha, that's a good one. So you can see here, this is the HeartMate 2, just as an exemplar. And it will walk you through some of the frequently asked questions. Can I do CPR? And the answer is yes, if you've gone through all of the troubleshooting. Can the patient be defibrillated? Yes. Can you externally pace this patient? Yes. What type of alarm occurs in a low flow state? Yes. And then all this other stuff. But you can see the diagram of what it looks like. There's the controller right there. There's the drive line that goes into the body and up to the pump. And there are the two cords that connect the battery wires to the batteries. And those are also things that you'll want to make sure are not loose connections when you do this. It tells you what map you're aiming for when you're looking at vital signs too. So you have one of those automated BP machines that's telling you what an acceptable perfusion pressure is. So this is just a quick short sheet on how each model would work. And for a while, we were keeping them on the ambulance. I'm going to double check and make sure that we have some ability to access that resource. So if you are out on a call and this happens, you can refer to this guide and it will be helpful. But we did for a while have one in the it's in the full, it's like with a hazmat book and things like that that we kind of just stuff away and don't really give a lot of thought to seeing that often because we don't deal with it as often, but it's a resource that's available to you.
Tyler, are patients instructed to keep all their gear together in one place? Or is it like, oh, we got our battery charger here, we got something else there, and it's like herding cats at the scene?
I think the best time for people to charge their batteries is at night when they're sleeping. So you'll often find that the main console that they use for charging or the main docking station that they use for charging will be in their bedroom. And then most people, especially if they have complicated medical equipment, will have a go bag, which is just all the spare equipment that they have. All righty. I think that's all I have for you. You can certainly feel free to peruse this document. It's actually very interesting and very sciencey, which appeals to me greatly. And I would encourage you to continue to review the protocols that we have in the Vermont EMS protocol book and continue to ask more questions. But that's all I have for tonight.
Thank you, Tyler.
I hope you all enjoyed that. I hope that was helpful. And I will
Thank
share
you.
Not a problem at all. And we'll share this with the rest of our friends on the squad and see what they think of me trying to lecture after a long day at work.
You have a minute to hang on for a training officer question from me?
Sure. Yep.
Okay, I'm
absolutely.
leaving.
Night,
Bye.
Brenda.
Bye.
All right, I'm
Bye,
gonna stop
guys.
sharing and then stop recording here. Somehow, how do I do this?